All right, let's talk about low back pain. If you're in training, you're seeing this every single day. It's one of the most common complaints out there, and honestly, it can feel a little overwhelming, right? So today, we're going to cut through the noise. We're going to build you a solid clinical playbook. Ready? Let's get into it.
Okay, first things first, let's wrap our heads around this number, 90%. That's huge. What it means is that for about 9 out of every 10 patients who walk in with low back pain, we're never going to find a single specific cause. We call it nonspecific low back pain. And you know what? Understanding this right from the start completely changes how we approach these patients.
So, if 90% of it is just non-specific, then what are we even here for? What's our job? Well, it's pretty simple, actually. Our job is to be a detective. We're here to hunt for that other 10%, the dangerous 10%, the ones who have something serious going on. That is our number one mission.
And how do we do that? How do we find that needle in the haystack? It's not with a fancy MRI scanner, I'll tell you that. It's with our two most powerful tools in the book, a really good history and a solid physical exam. This is where the real work happens.
So let's start with the big one, the one everyone worries about, cancer. We're usually talking about mets to the spine here. And the number one absolute biggest clue is a personal history of cancer. That's a huge red flag. But you also got to listen for other things, right? Like, have they been losing weight without trying? Has the pain been dragging on for over a month with zero improvement? And here's a classic one, pain that never goes away, not even when they lie down at night. Then on your exam, if you find a spot that is exquisitely tender right on the bone, you need to pay attention to that.
Okay, next on our list of scary stuff, infection. Think osteomyelitis or an epidural abscess. So, what are the clues? You're looking for signs that something is wrong with the whole system. Do they have a fever? That's a big one. Do they have a history of IV drug use, or maybe a recent UTI or a nasty skin infection? Any of those could be the source that seeds the spine. And on exam, just like with cancer, if you find a fever and that same kind of pinpoint vertebral tenderness, your alarm bells should be ringing.
All right, moving on to something you'll see a lot more often, nerve root pain. The fancy word is radiculopathy. This is when a nerve getting pinched or irritated as it leaves the spine. And the classic story here is sciatica. You know the one, that sharp electric pain that zings from the low back, down the buttock, and shoots all the way down the leg. Sometimes they'll tell you that if they cough or sneeze, bam, the pain just shoots right down. These are all huge clues that point us to one very specific physical exam maneuver.
And that test is the straight leg raise. It's so simple, but so elegant. So what you're doing is, you've got the patient lying flat, and you slowly lift their straight leg up. As you do that, you're gently putting the sciatic nerve and its roots on stretch. Now, if lifting that leg somewhere between, say, 30 and 70 degrees makes that exact sciatica pain shoot down their leg again, that's what we call a positive test. And it's a really strong sign that there's some nerve root irritation going on.
Okay, we've talked about red flags, but now we have to talk about the reddest of red flags, the one thing that is a true drop-everything neurologic emergency, and that is cauda equina syndrome. This is when the bundle of nerve roots at the very end of the spinal cord gets compressed, and it's a really, really big deal.
Because this is an emergency, there are some questions you absolutely have to ask. Is there any new problem with their bowel or bladder control? Any numbness in the groin area, what we call saddle anesthesia? Is any leg weakness getting worse and fast? If you get a yes to any of these, that's it. They need to go to the ER, get an MRI, and see a surgeon, like right now.
All right, this leads us perfectly into the million-dollar question, the one you are going to grapple with all the time. To scan or not to scan? The pressure is real, right? Patients want to see what's wrong, and sometimes we feel like we should just order the MRI to be safe. But the evidence, well, it tells us to pump the brakes.
And the guidelines could not be more clear on this. For that 90% of people with run-of-the-mill, non-specific back pain, you should not be getting routine imaging in the first 6 weeks. It just doesn't help them get better faster. Actually, it can make things worse. Why? Because if you scan enough people, you're going to find stuff. Bulging discs, arthritis, things that are super common even in people with no pain at all. And once you find those things, it can lead down a rabbit hole of anxiety and unnecessary procedures.
So, what's the bottom line? It's actually pretty straightforward. You image right away if you're worried about those big, scary red flags we just talked about, cauda equina, rapidly worsening weakness, or if you have a really strong suspicion of cancer or an infection. For everyone else, you wait. If they're still in a lot of pain after 6 weeks of good conservative therapy, then you can start thinking about an image.
Okay, we've done our detective work, we've ruled out the dangerous stuff, so now for the main event. How do we actually help our patient feel better? Let's put together a treatment plan that's actually backed by science.
And believe it or not, the most important thing we can do, the absolute foundation of everything else, is education. Seriously, this is not some fluffy, nice-to-have add-on. It's powerful medicine. We have to set expectations. Let them know that most back pain gets better on its own. We have to empower them to stay active, and we have to fight against those old myths, especially that one about needing to lie in bed.
So once we've laid that foundation of education, we can start climbing the treatment ladder. The first step, always, is non-drug therapy. We're talking about things like physical therapy, putting some heat on it, maybe massage, or even acupuncture. If we need to move to the next rung, we can reach for medications. And first line is going to be an NSAID, something like ibuprofen. The key is lowest dose that works for the shortest time possible. If that's still not cutting it, then we can consider adding a muscle relaxant as a second-line option.
So let's make this super simple. A clear do this, not that list. Do encourage physical activity. Do try non-drug therapies. Do use NSAIDs if you need meds. Now for the don't list. Do not tell them to go on bed rest. Absolutely do not prescribe opioids. The risks are huge and they don't work any better. And here's one that might surprise you. Don't even bother with acetaminophen. The evidence is pretty clear it's just not effective for acute low back pain.
Whew. Okay, that was a lot. So let's boil it all down. Let's get to the key takeaways, the stuff you can stick in your back pocket and use on your next shift.
Now, this is one of those high-yield tables that's worth committing to memory. It's your cheat sheet for localizing the problem. So if your patient can't extend their knee very well and their patellar reflex is gone, you're thinking L4. Can't lift their big toe up? That's your classic L5. And if they can't go up on their tiptoes and you can't get an Achilles reflex, bam, that's pointing you straight to S1. Super, super useful.
All right, let's wrap this up with the final playbook summary. Number 1, most back pain is benign. Your job is to find the rare, serious stuff. Number 2, your history and physical are your superpowers for hunting red flags. Number 3, just say no to routine imaging in the first 6 weeks. And number 4, treatment starts with education and movement. And for the last time, avoid bed rest and avoid opioids. And I just want to leave you with this one last thought. We live in this amazing era of high-tech medicine, and it's so easy to rely on machines. But when it comes to low back pain, your best, most powerful, most sophisticated diagnostic tool, it's not the MRI scanner. It's what's between your ears. It's your ability to listen to a patient's story, to use your hands, to think critically. It is your clinical judgment. Don't ever forget that.